A man in his 20s comes into hospital experiencing these palpitations in his chest, and they last 25 minutes at a time. You ask him a couple of questions and he says that he has this pounding head, this chest pain, and this shortness of breath that he's feeling. You explore a little bit more deeper and he has a family history of atrial fibrillation. You find out that he drinks 7 units of alcohol a week and he drinks regular coffee. You decide to do a cardiovascular examination on this person and you find nothing at all. You decide to do an ECG instead and you actually find this initial slurring on the QRS portion. From what I've told you, what do you think this might be? From the title of the video, you may guess that this is Wolff-Parkinson White syndrome, and what we'll be discussing about today is what is it, the ECG surrounding it, and why do people experience these symptoms using the case study alongside it. Our heart normally conducts from the sinoatrial node to then go down the bundle of his, and then this is to allow both of the ventricles to contract at the same time. The way to ensure electrical conduction goes down the bundle of his is through having a fibrous skeletal structure containing connective tissue that is mainly located around the valves. And this helps to separate both the atria and the ventricle. Wolff-Parkinson's White syndrome is usually due to the failure of the atrioventricular electrical insulation found around here, in which these accessory pathways are formed that bypasses the AV node. These pathways can be right-sided, but they can also be left-sided, and in most cases they are found on the left side. From here we're looking behind the heart and we can see an example of a accessory pathway here that's going over the coronary sinus. And these accessory pathways tend to be made of ordinary heart muscle and thus do not conduct as well as compared to the Purkinje system. The main indicator of Wolff-Parkinson's White syndrome is usually due to the ECG. And to understand these common patterns, we need to understand what is normal. Conduction starts from the sinoatrial node and then moves towards the AV node here. And this is when you create your distinctive P-wave pattern as shown. Then the AV node goes down the bundle of his and you get some conduction moving from the left bundle to the right bundle, and this is where you get your physiological Q wave as the downslope is shown there. Then finally the conduction goes to the Purkinje fibers and most of it will travel to the left ventricle as its greatest vector, and thus you get your QRS complex as shown here. This is a person with Wolff-Parkinson White, and you can tell because they have this orange box which signifies the accessory pathway, and the yellow which signifies the electrical insulation that separates both the atria and the ventricles. Now, conduction begins to happen as normal, as signified by these 5p coins. You get conduction that goes to the accessory pathway and conduction that goes to the AV node. And therefore you get this P-wave pattern as shown here, as normal. You get some conduction going down the AV node as normal, and therefore you get this Q-wave as shown. However, there are some conduction going down the accessory pathway that will prematurely activate the ventricles as shown. And thus you get this upslurring of the QRS known as the delta wave. And the delta wave looks something like this on an ECG. Because of this upslurring will displace the Q wave as it has a greater amplitude according to its vector. And therefore, you will see this pattern only. Conduction will then begin to occur as normal down the ventricles, and therefore you get a continuation from the upslurring, creating that QRS complex. As you can see, this is somebody with a delta wave as shown in Wolff-Parkinson's White. And if you see an ECG like this, this is known as a Wolff-Parkinson's White pattern rather than syndrome, because the syndrome describes the symptoms that somebody experiences, not just because of having the presence of the delta wave in the ECG. As I said before, accessory pathways can be on the left side or it can be at the right side. But the best place to know if an accessory pathway is left-sided or right-sided is to look at V1 on the ECG, as it always begins to look at the right side. The reason that we use V1 is because we can tell whether the accessory pathway is on the left or the right. Because if the conduction moves towards V1, this is a positive deflection, and if it moves away, it is a negative deflection. For example, if the accessory pathway starts from here and goes away, we're going to see a negative deflection. But if the accessory pathway from the opposite end and goes down towards V1, we'll see our positive deflection as shown here. So therefore, a more visual representation, as you can see, conduction from the sinoatrial node goes down, and suppose the accessory pathway is on the left side, the ventricle on the left will be prematurely activated, and thus conduction will move towards V1's side, and therefore you get this positive deflection that is seen here. Now take the flip side, where now instead the accessory pathway is on the right. Conduction goes from the sinoatrial node, the right ventricle is prematurely activated, and now the conduction will move away from V1, and thus you get your negative deflection as seen here. It is important to note that accessory pathways can allow conduction to go down the heart. It can also allow conduction to go up the heart, but it can also allow conduction to go both ways, and this tends to be the most common. The reason why that some people with Wolff Parkinson's White pattern don't tend to show symptoms is because when the conduction occurs from the sinoatrial node and one goes down the accessory pathway and the other goes down the AV node, the two conductions tend to clash, and thus you get this delta wave pattern that's seen all the time. However, there is a normal phenomenon that can occur in the heart which can cause the conduction to loop on itself again and again and again, and this is known as atrioventricular re-entry tachycardia. And therefore, when someone has something like that, they get ECGs that can look like this. And this is when people tend to show symptoms. So let's explore a little bit how these ECGs can be found. We always assume that conduction occurs as normal from the sinoatrial node to the AV node, and then goes to contract both ventricles at the same time every single time. But this is not true. Sometimes we get the odd contraction that can occur elsewhere, and for example, this could occur in the atria as shown here. And this is what we call ectopics. And we can identify ectopics sometimes on an ECG. For example, you get your P wave here, and then suddenly you have another P wave really early on, known as a premature atrial complex, aka your ectopic. Factors increasing ectopics can be lifestyle related. It can be smoking, drinking alcohol, dehydration, or it can even be lifting up heavy weights. It can even be biological, like thyroid disorders. But more than not, ectopics in majority are quite normal. In fact, we can have 1,000 per day and they pose no issues at all. The problem becomes is when the ectopics are more frequent than normal, and if the person is experiencing symptoms. So let's explore why our patient in the case study had the symptoms that he did. So as before, you get your conduction going from the sinoatrial node. One goes down the accessory pathway and the other goes down the AV node, and they'll clash together. But then you'd get your premature atrial complex, aka your ectopic, that can occur. One will go down the AV node and the other will attempt to go through the accessory pathway. But in this instance, the accessory pathway's refractory period is much longer, and it will say, actually, no, I will not allow conduction to go through. And therefore, the conduction that came from the AV node, it can now go up the accessory pathway and loop back on itself, and this is known as atrioventricular re-entry tachycardia. And when that occurs, you get these narrow complexes that form when you do an ECG. And the reason you get narrow complexes is because it's going down the AV node, down the bundle of his, which is the fastest conduction in a normal physiological route. So let's explore the opposite of that. In the opposite instance is where you have your premature atrial complex, and one will go down the accessory pathway, and one will attempt to go through the AV node. But this time, the AV node has a longer refractory period, so therefore it says, no, I will not allow you to go down the AV node, and therefore this gets blocked off. And when that gets blocked off, it will now go up the AV node and loop round on itself the opposite way. And when you get something like this, you would get a wide complex. And the reason you're getting a wide complex is because you're going up the AV node instead of down the AV node, which is not normal. And therefore, as you can see, your normal Wolff-Parkinson White pattern has now changed into the wide complex atrioventricular re-entry tachycardia. To summarize what we discussed so far, here you have is your Wolff-Parkinson White pattern, and by having these premature atrial complexes that could occur, you can either have the narrow complex, in which you go from down the AV node and up the accessory pathway, called your orthodromic Wolff-Parkinson White syndrome, or you can have it going the opposite way, in which it goes down the accessory pathway and up the AV node, giving you your wide complexes, aka known as your antidromic Wolff-Parkinson White syndrome. And these two are going to cause your symptoms, but this pattern itself will not. Due to the patient's lifestyle, he increased the chance of having these ectopics, and thus an atrioventricular re-entry circuit was formed, and this led to the heart having a very fast heart rate. Because of this, the heart was unable to deliver blood effectively to the vital organs needed, and thus the patient experienced this pounding of head and the shortness of breath. When people experience these episodes, they can usually self-terminate. One way is through an ectopic, which can break the conduction cycle. Another way is through us intervening, such as through vasovagal maneuvers. One way is massaging one of the carotid arteries. Another way can be through medication, such as adenosine. These methods can stop the cycle, but it's not going to get rid of the accessory pathways here, so therefore it could happen again. One way to ensure that it never happens again is through a method known as ablation, and we can firmly remove the accessory pathway, and thus people can live a normal and a healthier life. Thank you for watching. If you really enjoyed this video and you want to know more about Wolff-Parkinson White syndrome and the ECGs surrounding it as well, do check the links in my description. Thank you.